My name is Lori Chelius, and I'm the project manager for the California Improvement Network. Today's webinar is entitled Targeting High-Risk Medicaid Patients, and we will hear about the Hospital-to-Home program, a demonstration project of the New York City Health and Hospital Corporation designed to help manage and coordinate the care for high-risk Medicaid patients. We're joined by Dr. Maria Raven, Assistant Professor in the Department of Emergency Medicine at UCSF, and Catherine Kuroda, the Social Work Supervisor for the Hospital-to-Home project. So just before we begin, a couple of housekeeping items. The session will be recorded. We will be posting the slides on the CIN website in about a week. And if folks could just please turn off ringers and pagers, et cetera, and no hold music, we'd really appreciate that throughout the call. The speakers are going to talk today for about 40 to 45 minutes to make sure there's plenty of time for questions and answers. So if people have questions, you can ask questions in one of two ways. You can either raise your hand on the right-hand side, or you can also type into the chat box. If you have a logistical question, you can just ask that question to the host only. But if there's a content question, please put that to all participants so everyone can see the types of questions that are out there, and it might generate some more questions as well. So today's speakers, Dr. Maria Raven is an assistant professor in the Department of Emergency Medicine at the University of California, San Francisco. She completed her emergency medicine residency training and a CDC-funded fellowship in medicine and public health research at Bellevue Hospital, NYU in New York City. And while in faculty there, she oversaw the implementation of the hospital-home program that we'll hear about today. At UCSF, Dr. Raven works clinically in the emergency department and conducts research related to emergency medicine payment policy and frequent users of the health system. She also works with the San Francisco Health Plan to assist with management of their highest cost members. And we're also joined today by Catherine Kuroda, who's a licensed clinical social worker in private practice in Manhattan, and previously was the social work supervisor at Bellevue Hospital Center for the Hospital and Home program. She has a master's in social work from Columbia University and completed postgraduate training at the Institute for Contemporary Psychotherapy and the William Allenson White Institute, in addition to building skills in motivational interviewing and harm reduction. Catherine has over 10 years experience working with adults in inpatient and outpatient hospital settings in New York City. And she's developed an expertise in working with medically and psychiatrically complex individuals with chronic illness and multiple psychosocial stressors. Her areas of interest include empowering marginalized populations and staff development to minimize compassion fatigue. So with that, I will pass the presentation over to Dr. Raven, who will kick things off.
Great. Thanks, Lori. So thanks for joining us. And as I go through these slides, I will try to keep an eye on that lower corner if people have questions and try to answer them to the best of my ability as we go along. So as Lori mentioned, Catherine and I were a part of a HHC Health and Hospitals Corporation state-sponsored program called a Chronic Illness Demonstration Project, and that's what we're going to talk about today. So just to give you a little bit of context, the issue here is that a small percentage of patients account for a disproportionate share of healthcare use and costs. I think a lot of us know that, and it's becoming a sort of hot issue to try to confront. And this is just a little graphic to give a sense of the scope of the problem, especially within Medicaid and within the SSI disabled population, which was a large portion of the population we served with the Hospital-to-Home project, and a lot of what California is dealing with here in Medi-Cal as these folks are enrolled into managed care. So here basically you can see on the left-hand column a small percentage of patients account for a really, really large percentage of costs, so that 3% account for a full total of 30% of costs, and when you get up to 10% of patients, you know, you're over 70% of costs. And that's really pretty true for many different types of patient populations. All right. And, you know, as much as people would like to, and it might be easy to try to sort of pigeonhole this type of population and try to say, well, you know, they're all like this or they're all like that, so let's try to do this one type of intervention. You know, it's actually a really heterogeneous population. They have a wide range of issues that fall within a couple different domains of problems, but for any given person, you know, whatever is coming out for them at the time might be really different, so that it's difficult to have any kind of one-size-fits-all solution. And then questions that come up and that I'm going to try to answer, and Catherine's going to try to answer during the presentation. So who should we intervene with? So defining and identifying your population is really important for multiple different reasons. The program, what should we do? You know, there are limited dollars. You have to define some type of scope of services. There's actually not a lot of evidence on what works. There is some evidence on what doesn't work. There's a little bit less evidence on what kinds of things actually have been proven to work from, I think, a cost and sort of patient-centered outcome standpoint. Also, I think, as we all know, you know, there are a lot of silos in terms of services and payments that just make it difficult to coordinate care for these patients that use multiple types of services. And then there's the question of money. So who's going to pay for something? And we'll talk about that a little bit as well. So I wanted to start out just by illustrating the complexity of some of these really high-cost patients. So this was actually the first person that we enrolled in our hospital-to-home program, and that was, I believe, August 1st of 2009. And she was someone that we already knew quite well. And so when it turned out she was eligible for our program, we were very enthusiastic to enroll her. And she was a woman that got brought in almost every day, sometimes multiple times a day, to our emergency department by EMS, mostly, well, pretty much completely due to alcohol. And I just want to show you here, so if you look at her ED visits, and yes, these numbers are accurate, if you look in the 12 months ahead of time, before she enrolled with us, you can see she had close to 70 emergency department visits in that year, and about close to 10 inpatient admissions. And then if you look 12 months after she enrolled with us, her ED visits actually went up, and so did her admissions. And we were working with her very intensively, trying to partner with folks on inpatient psychiatry, and we were doing this and with housing. She was homeless, trying to get her housed, a couple involuntary hospital admissions for suicidality. And you can see that it wasn't until 32 months after we started working with her that we really start to see her visits and costs come down. And I'm going to move on next. And this is looking at her costs. And these, again, these costs are pretty staggering, and this would be an extreme example of the type of high-cost patient that enrolled in our program, but we did have patients that cost this much money to Medicaid. And you can see that in the 12 months after we enrolled her, her costs actually went way up, and these were due to, you know, pretty necessary long-term hospital admissions for very complex psychiatric and substance use issues. And then when you look at 32 months out, her costs dropped drastically, and she eventually did get housed and really stabilized, but it took this long. So the point that I'm trying to illustrate here is that when you're thinking about programs like this, A, you can't necessarily expect immediate results, and B, if you're going to evaluate this type of program, the best thing you can do is try to plan for an evaluation that can take into account, you know, more than just 6 months, even more than 12 months. So our program was sponsored by the State Department of Health in New York. It was one of 6 contracts with the state. So ours is just one. There were 5 others across the state that had different program models. Our model was an intensive care management and coordination intervention. All the patients in all the projects were fee-for-service Medicaid patients that were high risk for frequent hospital admission. And these patients have subsequently are getting all moved into managed care, but at the time they weren't. Cumulatively, over a little less than 3 years, we enrolled 540 patients across 3 New York City public hospitals. We had staff at 3 hospitals in 3 different boroughs, Manhattan, Brooklyn, and Queens. And now our program has been codified sort of as being rolled into a part of what's called a Health Homes Initiative, which is a federal initiative that pays service dollars through Medicaid for care coordination. So we're happy about that. So what we did was to find and enroll patients that were identified by the State Department of Health as high risk and high cost. And I'm going to talk a little bit about how the state went about identifying these patients in a little bit. We intervened with them with a goal for the state of reducing Medicaid expenditures. And as you may or may not know, the main drivers for costs in Medicaid, and I would say it probably extends to healthcare in general, are inpatient stays. Long-term care also factors in, less so in this particular program, but generally reducing hospital admissions is where you're going to be able to cut the most costs. A lot of people are focused on emergency department visits, and in and of themselves, that is not a huge cost center for Medicaid, just a point of interest. We aim to improve health and social outcomes, so those were very important to us, obviously, and this was all for $291.50 per patient per month. So that was our monthly fee from the state that we would get. And as John Billings, who developed the method of identifying these patients, and we worked closely with, likes to say what we did was provide supportive housing without the housing for the people that in our program that were not homeless. We did have a number of homeless people as well. So in terms of the population, outreach and enrollment was one of our biggest challenges, and this was a challenge for all the programs across the state. So let me just explain how we were given the list of names that then we would outreach to. So what the State Department of Health did was they got a bunch of Medicaid data. They got about 5 years of data. And then there's an algorithm developed by the person on the former slide, John Billings, that allows one to identify patients that are very high risk for having an admission in the following 12 months based on their service utilization in the prior 3 years. And so what the state did was they said, all right, we're going to take all this data, analyze it, get a bunch of names. Everyone gets a risk score for admission in the next year. And everyone with a risk score of 50 or greater, we're going to give you those names, and you are going to have to go out and try to find those patients, and those are going to be your enrollees. So what ended up happening was they gave us lists of patients, and it turned out the data that we got from the state was basically whatever data was in the Medicaid administrative database, so address, phone number, name, and as you might be able to imagine, a lot of that information was either incomplete or completely inaccurate. And so a lot of the programs were having a lot of trouble finding folks, and so they actually ended up lowering the risk score so that we ended up getting additional patients that weren't as high cost to begin with. Still pretty high cost, but they had to lower the risk level a little bit to allow us to find enough people. Other things that we did to try to find the patients that the state gave us was to improve our ability to get accurate information about them by conducting data matches. So we developed memorandums of understanding that let us share data with kind of key city organizations and agencies, for example, the Department of Homeless Services, Common Ground Community that did a lot of homeless street outreach, some of the independent shelter programs in New York City, pretty much any organization where we thought that our patients might be, could we find them, we would try to share data and see if we could intersect and get more accurate information for people. We also developed a mechanism for us to be able to identify patients when they came into one of our facilities, so that our staff had BlackBerries and they would get automated emails when an eligible or enrolled patient came into one of our facilities, so that we could then go right to where they were and try to engage them. And I'm going to hand it over to Catherine, starting here.
Thanks, Maria. Yes. Okay. So our program staffing structure, while a lot of case management programs are led by a nurse or in different formats, the pilot project that we did in advance of this, we really realized that most of the interventions we were doing were psychosocial in nature. And so our staffing structure was a social work supervisor at each site supervising what we called community-based care managers. And even in that title, what we really wanted to emphasize was we weren't just hospital-based, and we wanted patients to know that, and we wanted agencies to know that. There was a ratio of 1 to 25 care manager to patient ratio, which is really low when you look at a lot of other programs in the literature out there, and more in line with an ACT model. We had a full-time housing coordinator that was shared among all 3 sites, and some level of dedicated primary care at each site, so that there was consistency and a relationship was developed with primary care. Rounds could occur with the team because there were many patients who did not have a primary care physician prior to enrollment. So the ideal care manager, one of the things that we really found is you want to get the right people on board, and that none of this work is possible without getting the right leadership, without getting the right supervisors, and then getting the care managers who are going to really be carrying this out. And we had a range of people with different experience and backgrounds. We had some people who had their high school degree, but many, many years of work with people with substance abuse and homelessness. We had people that were working towards their master's in social work or public health or related fields. And what they all had in common was a desire to be there. They had a shared mission of the program, and they were really able to make patients feel welcomed, cared for, and develop a relationship of trust. And without that, as you'll see in the case example coming up, it goes a long way to help somebody take the necessary steps towards stability and greater health when you have that trusting relationship. And then the training schedule, we really put a lot of ongoing, upfront and ongoing training for these care managers to really emphasize respecting patients and meeting people where they are. So really being patient-centered, not just talking the talk, but walking the walk, and really making that happen. And also, as I was looking at the slide earlier with Maria, looking at meeting people where they are in regard to the actual training schedule, was we actually held the trainings at all of the different sites, which I do think went a long way as far as, trading off everybody having to travel. So in program development, I think that was really helpful. So what we did once we enrolled patients was we did a very in-depth patient health assessment. It was about 40 pages long, and it was usually not completed in one appointment with a patient. And it really gave us a comprehensive view of all of the different areas that we might be able to make an impact. Things that the patient might not think to bring forward, but that we would identify and say, oh, well, did you know about this? Or this is something else we might be able to work on together. It also gave us a lot of baseline data, and it gave us a good comparison point because some of the tools we did every 6 months and some yearly.
I would just add in there that no one would suggest any of you all use a 40-page assessment.
I would agree.
That was a little bit of a live and learn, but we wanted to conduct a lot of research related to this too. And it was like triple spaced. Come on, no, but it was very long. So
it was long. Sometimes it was good when patients were admitted because they were a captive audience. So once we had our assessment done, and we developed a care plan with the patient. And while it was again patient-centered, it was a collaborative effort. It wasn't only the patient's goals. I mean, the patient is not usually going to have the goal of improving their hemoglobin A1C, but that's something that we are going to bookmark as, okay, that's not, this is still going to go into the care plan. And we used a lot of motivational interviewing. So really trying to not shake a finger and say, you really need to stop drinking, because we would really probably be the millionth person to tell them that, and it hasn't made a dent so far. So how can we shake things up? How can we treat them with respect and look to reduce harm? So, we'll talk a little bit more about what we did in the upcoming slides. And we begin to work with the patient on first immediate needs and then long-term goals. So something like getting someone an appropriate winter coat, a cup of coffee, just to really kind of help engage them, and then looking at the more long-term goals, like linking to primary care. That could be something immediate depending on their willingness, or something that's more long-term. Housing is usually always long-term just because of what it entails. Okay.
All right, and
Maria.
so thanks, Catherine. So the issue of homelessness came up. We did some pilot work leading up to this program, and realized through that we did a bunch of qualitative interviews with some of these patients when they were in the hospital in advance, and also ran a small pilot program, and realized that homelessness was a huge issue. And so we did make partnerships with homeless services providers a priority from the get-go. And we used some of the money from the state and also from a separate grant to fund a full-time housing coordinator. And basically, the job of this person was to work across all 3 of our sites and all the enrollees and work with the care managers just focused on issues related to housing, which there were many. So it could be anything from, they would meet with the patient, figure out something like, were they in shelter? Did they have a case manager there? Did the patient understand if they had a housing application pending? Maybe they had a housing application rejected, and it was because it hadn't been really comprehensively filled out and the patient hadn't been fully evaluated for all the qualifications that might get them into housing, and we would redo that. Or they could never make it to an interview, and we would help with that. So a lot of different things that patients really had a lot of needs around housing, and I think it was really helpful to have this person that was kind of our go-to person for housing. We did not have any ability to prioritize any of our enrollees for housing. That was just one of the stipulations that actually New York State was very particular about. We could not move anybody up in the queue. So what we tried to do was just to the best of our ability optimize their chances to be eligible for housing and get them to their interviews and get all the preliminary steps done they needed to get done. And I think we were able, within the constraints of the New York City housing market during the program, to do a really good job with this aspect of things.
I'd agree with that. Okay, so what we're, thanks, Maria. So some of the typical tasks that we did as interventions were linkages to medical care, and that was anything from where do I go to literally, the next bullet, accompanying them to the appointments. Collaborating on discharge planning with the inpatient teams. Often they didn't have a complete picture, so giving our input, giving their input, looking at what's the best plan here. Cell phone provision and support. We gave our patients cell phones if they didn't have one already or a reliable means to communicate. This is particularly helpful for our homeless patients who definitely were more transient, and enable them to keep in touch with the team when a problem arose, when they needed a medication refill, and while managing them with a task. And there were some people that came up and wanted to join the program in order to get a free phone. It definitely was a worthwhile intervention to be able to keep collaborating. Transportation assistance, and this ranged from Metro cards to helping somebody apply for Access-a-Ride or linking them to an ambulance service. Entitlements enrollment, one of the first steps with the housing application is if they don't have a source of income, they're not going to get housed. So helping them apply for public assistance, which I'm not sure how it is in California, but in New York it's quite a process and laden with a lot of mistakes. And also SSI and SSI appeals for disability claims. and food stamps, I should add, sorry. And facilitating housing, so this, again, working with the housing coordinator, working with the shelters, and also advocating for those that were already in housing but perhaps not getting the level of support they needed, or someone in city subsidized housing that had mold in their ceiling and they had asthma. So housing, was, even for those that weren't homeless, was something that we often advocated and intervened about. Home visits and safety assessments, to see somebody in their home, to see what is in their refrigerator, how they're doing, how they're coping, are they safe, was a crucial component. Reminder calls, alarm clocks, pill boxes were small things that we did. Support groups, we were fortunate at 2 of the sites to have support groups, and the feedback was really wonderful, that it was a great place where they didn't feel labeled and they could just come together, that they were all coping with some sort of chronic illness, whether it was substance abuse or diabetes or both. 24-hour call line with our staff on the other end. So patients, might call just because they're lonely, they're thinking about picking up a drink, they need assistance because they just got kicked out of their apartment. It ranged, but we really were able to provide that. And the Patient Necessities Fund was crucial. Maria did a great job in helping us get that fund built, and that enabled us to buy the alarm clocks and the pill boxes and, buy someone a cup of coffee or winter boots.
Thanks, Catherine.
You're welcome. Okay, so case study, Ms. W. So she is a 44-year-old Puerto Rican woman, and she was enrolled. She's one of our first patients. She was enrolled in September of 2009, and she has morbid obesity, diabetes with complications, hepatitis B, hypertension, CHF, renal insufficiency, asthma, tobacco use, prior IV drug use, depression, and at least 2 suicide attempts in the past. At the time of enrollment, she was living in a homeless shelter, and she moved into supportive housing in December of 2009, so not too long after we had enrolled her. She had frequent hospital admissions for high blood sugars and related infections, difficulty remembering to take all of her medications, and her depression impacted her motivation for treatment and attending appointments. So so there's a lot going on with this woman. I think you can see with all of these medical and other diagnoses, along with being homeless, it's complex. So post-enrollment, we provided her with a cell phone, with appointment reminders, with transportation assistance, and moral support. And this was huge because this woman, with all of these diagnoses, had never actually been to an outpatient clinic appointment. She had only been to the emergency room. She had only been admitted. She had never attended an outpatient appointment. So, having to help her adjust to that and get there was really huge, and connecting her to a primary care doctor. The relationship with the primary care doctor and the care manager was really crucial in helping her to move into supportive housing, as was our housing coordinator. But what had happened with her, and I think it's worth illustrating here, is she was approved for housing and she just needed to go pick up her check. She had a move-in date, and she had come in for her lab work and gone home and was all excited about moving the next day. And she got a call from the hospital saying, you need to come in and you need to go to the emergency department and you need to be admitted because you are in diabetic ketoacidosis. And she said, hell no. Those are her exact words. I am not missing out on housing. I've been homeless for over 10 years. My health can wait. I'll go to the hospital after I move in. And we were able to, because of her trust and relationship with the primary care doctor and with our care manager, to convince her, we can assure you you're not going to lose this apartment. You won't move in if something happens to you and you die. So what can we do here to help you feel okay with coming to the hospital? And so she did come and she did get admitted and she did successfully move into her apartment. But it was a stressful time, I think, for everybody. We assisted her with mental health, substance abuse treatment, and smoking cessation, which was great. Again, she was really engaging in many of these things for the first time. The housing coordinator I mentioned. The SSI appeal and public assistance workforce. So she had actually been mandated by public assistance that she was able to work and report 30 hours a week to the Human Resource Administration, which oversees public assistance here in New York. And if she didn't, then she wouldn't be able to keep her public assistance payments. And we advocated that there's no way that she, I don't know what doctor evaluated her, and, we want to support people in vocational rehabilitation, but that we really felt her medical conditions and the amount of appointments that she needed was not appropriate for, that decision was not appropriate. And we assisted her in her disability appeal, and she did receive SSI. So we were very pleased with that so that she could have an income to pay her rent. She attended monthly hospital-to-home support groups, recovery clinic, which is a substance abuse clinic for those that have sustained recovery for a while, and she also attended groups at her residence. We encouraged self-care and not putting other needs first. She loved her granddaughter very much, but would at times not want to disappoint her daughter by saying no, and would bring her granddaughter to her psychiatry appointment and, really not make the most of that appointment. So really being able to help her look at the importance of taking care of herself. And active listening, just validating her feelings and her experiences. So when you look at 12 months pre-enrollment to 12 months post-enrollment, she had 3 hospitalizations 3 months prior versus 1 post-enrollment, and that was at 1 in December that I had mentioned. And we had over $60,000 in Medicaid savings in 1 year, and that included our program costs in that number. And then looking at what is progress. So I want to encourage anybody trying to do this kind of work to have a realistic time frame. Change is something that takes a long time, and it wavers. You have 2 steps forward, a few steps back, and to not lose sight of celebrating the small victories along the way. So examples of small things that indicate progress: participation in support groups, making it to or through an appointment, reducing alcohol use, or someone who's diabetic who doesn't want to stop drinking, choosing something that has fewer sugar in it, like looking at those things. So maybe they're not sober, but they've reduced their alcohol, or they're making better choices. This is good for both patients to feel that they're making progress, and also to really help minimize the burnout with staff, because if you only are looking at, but they're still homeless, you're not going to keep wanting to go to work every day. So really looking at the small things. Big things like housing, regular doctor's appointments, and reduced emergency department and inpatient use. Those things will happen. Those things are progress, but they're going to take a little longer. And here we have, this is a drawing that was done by a 54-year-old patient of ours, Charles, who had chronic alcohol dependence, some spectrum of psychotic disorder, though nothing formally diagnosed, and had been homeless for over 20 years. And in the first 6 months when he was placed into housing, he spent every day out and about in his old stomping grounds, sleeping on the street, and our team and the street outreach team would try to bring him back to his residence so that he didn't lose it. Here in New York, there's a lot of old grand hotels that are renovated into supportive housing, and they're beautiful the way that they really, keep the integrity of these structures. And he was fortunate to move into one of these buildings. It was an old hotel near Times Square. And one of the things he was having so much trouble with was, I don't feel worthy of this place. This place is too nice. And all of the meaning behind home. We think of a house is not a home. What makes something a home? He really was having trouble having his own home. And after about 6 months, he started staying there with more regularity and actually started to want to think about getting in touch with his family. And when the assistance of his care manager, he called the number that he still knew. He knew, and they verified it online on the yellow pages, or the white pages rather, and called his sister. And it turns out the family had never changed their number because they were always hoping that Charles would call. And this was, a beautiful reunification, and it happened right around Christmas. The patient wanted to get a haircut and new clothing, and we assisted him with that. And in a patient support group where they were charged with, drawing a biographical sketch of themselves, this is what he put together, is the image of the Last Supper with his mother as the Jesus figure. And it was really quite moving for all of us. And his mother has actually, this was in 2010, has since passed on. But this was, I think, something that just really kind of illustrated something nice about the program and the interventions and how it can all come together.
Thanks. Okay, so from that beautiful picture to maybe something a little bit more practical here, talking about the finances of a program and who should pay. So I think you have to examine your target population and figure out, are they insured, and if so, by whom? If they're uninsured, are they going to be eligible for coverage under the Affordable Care Act? And these things make a big difference because in our case, it was in Medicaid's interest to pay for this program to see if it worked because they were, paying a lot of money for these patients. And, now I think with the group we're working with, that I'm working with in California, there are some folks that are covered under Healthy San Francisco. In other states, there might be an uninsured group that's uninsured now, but in 2014 are going to qualify for Medicaid under health reform. And so thinking about those sorts of things and who would be incentivized to pay for a program that would help lower costs. If you've got a big uninsured population that is not going to be eligible for coverage under reform and the hospital in your area has a lot of, they're offering a lot of pro bono care, maybe the hospital is the one that would be incentivized to pay. So really just thinking about that in terms of starting up a program, and then who has the moral and ethical stakes in the triple aim, which is improving the patient experience of care and reducing healthcare costs, taking those things into account. So I'm going to show you some data from our program, and the people on this call are going to be the first people to see these data. And so the big question is, did we save money, right? And we have a lot of other outcomes that we took a look at too, and we're in the process of analyzing those data as well. But I wanted to share some of these things with you because this is what we got to initially, and I think it's really important in terms of program sustainability. So there are a lot of caveats. These are based on Medicaid claims, and we got all of this information from the State Department of Health. There is a claims lag, so there's 3 to 6 months of a lag before all the claims are complete, and so we only have data through the end of December 2011, even though we had a lot of people that were enrolled beyond that date. A question in analyzing these kind of data is, in the month of analysis, was the patient actually eligible for Medicaid? And you have to factor that in, which makes the data more complex. And because of the limited amount of data we had through December of 2011, we were only able to study a limited cohort of patients for a limited time. Also, it's important to note, in the data I'm going to show you, we don't have a control group. And in the research John Billings has done with this patient population identified by this predictive algorithm, once you find these patients that are high risk of admission in the next 12 months, it's shown that if you don't do anything, then their costs in the following 12 months will rise. And so it's difficult to really show a full impact without having a control group, but because these patients were pre-selected as really being a high-risk group, I feel comfortable showing the before and after. The other thing that's worth mentioning is I told you that the state gave us a group of patients based on their risk score from the predictive algorithm, and initially they identified patients with risk scores at 50 or above, but then they lowered the risk score a little bit into the program to 30 or above. And the patients that have a risk score of 30 are probably going to be a little less expensive and perhaps a little bit less complex than patients with a risk score of 75, let's say. We had no idea what our patients' risk scores were, and we still don't know what they are. And so when I'm showing you these data, it's hard to say exactly where these patients fell in the risk spectrum. And so that's just one other issue to bear in mind. So we did a pre-post analysis. We looked only for patients that were enrolled continuously for a minimum of 12 months. So we didn't, for this analysis, look at patients that disenrolled and then re-enrolled with us, because it's kind of a question of what do you do with those months when they weren't enrolled? How do you sort of treat those months in an analysis? And it's a pre-post analysis comparing 12 months pre to 12 months post. We looked at the entire cohort of patients, and we also drew out the homeless subset, and that is patients that were referred to our housing coordinator and were confirmed to be street or shelter homeless at the time of enrollment. Did not necessarily mean that they would be eligible for housing based on New York City criteria, but it meant at the time of enrollment they were homeless. I wanted to share this slide just to give you a little bit of context, because you're going to see some numbers, and I think you've already seen some numbers that are pretty big, but it's hard to know just how costly people actually are without some context. So, and these are 2009, so I guess you could assume these have gone up a little bit per enrollee, but we were dealing with the disabled population, so you can see the average payment there can be as high as $29,000. But the average Medicaid payment, annual Medicaid payment for adults that's not disabled is just over $4,000. So just bear those numbers in mind. Excuse me. So looking at pre-enrollment Medicaid costs for our group, which was 172 people that had been continuously enrolled for at least 12 months, they cost more than that adult you saw back in that slide in a year each month, and they totaled an average of over $57,000 a year. When you pulled out the folks that were homeless at the time of enrollment, a little less costly, not quite sure why that is. It's a pretty small number, so I'm not sure if that would be necessarily representative, but I wanted to show you this because we continue to break out that group in the coming slides. So I'm going to show you a health services use and cost comparison. So these are average monthly Medicaid costs, and we are including the program costs in the post-enrollment period. So this is accounting for the cost of the program. Now, if you look, the blue bar represents the people in our population that were not homeless. Then the red bar is folks that were homeless and remained homeless. And then we have a group that were homeless that were eventually housed. And so if you look in the prior 12 months, you can see that costs were, around $5,000 for the group that wasn't homeless, slightly lower going down from there. And then if you look at the first 6 months after enrollment, costs seem to spike a little bit, especially for the homeless group, pretty level, maybe a touch lower for the remainder of the group. And then it's really in the second 6 months where you start to see some program savings. And so I think that's really important, and it kind of goes back to what I mentioned before, that you can't expect to see a lot of savings right away, and you might even see spikes. And I think some other programs have showed something similar, because for some of these people, even though they were high cost and they were coming into the system a lot, they didn't necessarily have a lot of their complex medical issues really thoroughly addressed. So they might end up, having, we had a lot of patients that had actually cancer that was underlying all the other medical problems they had that had gone undiagnosed or untreated, and things like that, that can cause a preliminary spike. Now, if you look at emergency department visits per month, you can see in one group they fell steadily. In the group that was initially homeless but then housed, they had a little spike and then went down. And for the group that was homeless but we did not house, and again, these are small numbers, we didn't make that much of a dent. Maybe a tiny drop from baseline, but really not much of a difference. Now, I will put out there that I think one thing we found was that these are treat and release emergency department visits. So all these ED visits are visits that did not lead to a hospital admission. And I think one thing that we found initially is patients that came into the emergency department a lot, we actually would see a spike sometimes in those numbers, but we would see a decrease in hospitalizations because of the support we were able to provide to folks in the emergency department. Some of the patients were able to be treated in the emergency department and released rather than get admitted to the hospital. And so that might account for some of the spike that you see there. Now, inpatient visits, again, this is really where the money is. And you can see here that Among all the different groups, we did show a drop in inpatient visits on average per month throughout the course of the program. And this is inpatient days. And I think this is pretty interesting because you can see here that in the group that ended up being housed, there's a pretty significant drop in the average number of inpatient days per month. And I think that's a pretty significant finding, and I think it makes a lot of sense because a lot of times, you know, it's difficult to find a good discharge solution for a patient that is homeless, but once they're housed, less of an issue. And so ending here, key lessons that we learned as a part of this work. There were many. These are some of them. First of all, I really think that the homeless cohort of patients is a group of patients that is different and needs a different level of services. We did it with the housing coordinator. It just opens a whole other host of issues for the patients themselves and in dealing with the system that, you know, I think if you have something that you can plan for and partnerships you can make in advance in this sort of intervention, that's going to really go a long way. Outreach is a huge part of the initial work, and I think we're finding something really similar here at the health plan. Even though these patients are coming into the health system frequently, they are not easy to find out in the community. And so if you have a way to find them in the healthcare system, which we did, in some cases it can be really, really helpful, but you really almost need to find people that are willing to be kind of private investigators that can really do the work to try to hunt some of these folks down where they are and see if they'd be interested in enrolling in this type of program. As Catherine alluded to, hiring is really key, getting the right people that really want to do this kind of work because it's really hard. And it can be really challenging and emotionally draining, but also really, really rewarding. In terms of evaluation, because I think probably most people would want to do some sort of evaluation, you know, and it would range in complexity. Really try to determine in advance how able you'll be able to obtain comprehensive, accurate data. And I think with a lot of these CMMI grants that have been awarded from the federal government, they really want to see rapid change within, you know, 6 months, 12 months. And unless you have data that you can analyze almost in real time accurately, and you know it's accurate data to see if you're making a difference or not, it makes it really, really difficult to kind of get a sense of how you're doing with your program and if you need to make changes. Involve stakeholders as early as possible. So wherever you're coming from, whatever your perspective is, if you're coming from the hospital perspective, managed care, whatever it is, if you're a community-based organization that wants to do something like this, the more in advance you can kind of think through who you would need to partner with and start to develop those partnerships early, it's going to be really helpful. And then finally, expect potential cost increases in the first 6 months, and then really plan for more long-term gains when you're talking about savings, and I would also say behavioral change. So you really have to, in programs like this, working with these complex patients, take a long-term view. And finally, I wanted to give thanks to these wonderful people and organizations, and a shout out, Krista Olson really helped with a lot of this data analysis, and she deserves some serious praise. So I'm not sure if she's on the call or not, but I will leave it there, and we're happy to take questions.
Great, thank you guys so much. Just a couple of questions that came through that we can start things off with. You mentioned before the assessment that you had a pretty lengthy, I think you said 40-page assessment. What components of that assessment did you find the most useful, and what would you emphasize if you were to do a shorter version?
Catherine,
you want to take that, or you want me to take that?
I can take that, but I'd be curious from your more research-oriented perspective what you would say. I think, you know, I mean, first of all, the assessment, you know, had validated tools like the WHO's Assist and the PHQ-9. We did the PAM, the SF-12, but we also did a really in-depth psychosocial assessment. I think the most, I'd say it's a little different, you know, patient by patient, but for the most part, I think the most important thing is like understanding who is this person and what is their history and where are they now. So that includes like most of, I don't think we have the slide here today, but I think it's about 60 to 70% of our patients report social isolation. A lot of them have a significant history of trauma. So understanding what sort of forms where they are today and what they're having trouble coping with, I think really kind of helps you develop empathy for the patient and also help understand where they're coming from. I think that the substance abuse piece was important so that you could kind of, especially for the active users, to get a sense of what is their drug of choice, so that we can look at ways, for instance, we had a lot of patients with, alcohol issues that had never really been interested or, I think, properly educated about the medication alternatives. So maybe they don't want to go to AA, maybe they don't want to go to an outpatient clinic, but have you ever tried Camprol? Have you ever tried Vivitrol, like naltrexone? Like, are there things that that we haven't thought of here? And lastly, we would ask them kind of like what they would want to see accomplished, like ask them what a typical day is like. I think that was good to understand again. What is a typical day like for them, because that's going to impact how we're intervening. Is a typical day going down to the local park and drinking? Because if it is, how are we going to fit an outpatient appointment in there, or if they're on the street? So I think understanding the patient and environment was crucial.
Yeah, and I would add to that, we've here at the health plan, we're doing assessments, and we shortened it pretty drastically. So I think we kept some of the domains Catherine mentioned, and that might be a good way to think about it, like, mental health, substance use, medications, housing, social isolation. Kind of think about it in terms of domains, and then what questions you think would be the minimum that you could kind of get a sense of what you need to get from the patient. One thing I think that it's important to bear in mind too is, and we try to emphasize is when you're talking to someone, if these are patients that have heavy use of the healthcare system, really important to kind of start the focus, well, what brought you into the hospital last time, or what brought you into the emergency department last time, and why was that? What happened before you went in? Was your health declining and you could kind of feel it, but you didn't call anybody because you're used to just going into the ED or the hospital? Or did you try to call your primary care physician or a family member before? And how was your hospital experience? What was it like when you were there? Did you understand your discharge instructions? Finding a point of focus that the patient can really remember and relate to, you can get a lot of really valuable information and find some potential points of intervention from that.
That's a great point. And I would add, where are they accessing this care? Is it an emergency room? Do they already have doctors? Are there other agencies in the community that they're working with? And then seeking to obtain consent to be able to work collaboratively with those agencies. So try to do that from the get-go. And for those that are homeless, finding out where they hang out. If they're on the street, get specifics. I don't know how much is similar out there, but that was something that was invaluable.
I see a question popping up. Should I address it, or?
Go for it.
Okay, I see here, will the patient assessment tool be shared along with the slides from today's call? Sure, no problem. I see a question, what services were you able to get covered by the 90-10 federal state match for health home services? This pays for care coordination. So anything that can be considered care coordination is essentially covered by the 90-10 federal state match. So for HHC, they defined a population based on the health home eligible population, and it's essentially services that are beyond any of the medical service that involve coordination. That's what you can get covered. I hope that answers the question.
And I'm seeing a question, were all patients able to be linked to a specific primary care physician consistently? And that varied across the sites for a couple of reasons, but for the most part, yes. For those that were linked to the primary care physician, they would see that physician ongoing. And some of them who may have had another primary care physician, actually, but they might have had a different resident each time, even if it was like the same attending. That wasn't always ideal, and they would actually end up working with our primary care physician, which was amazing because we were able to have rounds with the doctor every week and ongoing communication throughout the week so that we could really kind of look at, like, did you know this happened? And he could help us flag, like, watch for signs of this, or like this appointment's really important, and, you know, help them fill this medication. So yes, they were, and that was, I think, something that helped us achieve some success.
Great, thanks. I have a couple other questions that came through over here. From an outreach perspective, do you guys have any lessons learned on tips in terms of reaching the enrollees? Anything on that front?
Well, I think we did a lot. So we would basically take our list of patients, and we, as I mentioned, had data sharing agreements with a lot of different other agencies. So, for example, with the shelter system and with the street outreach teams, every month we would give them our patients. They would run the list and see, oh, you know what, this patient popped up here. And that would allow our staff to go to that place, like as soon as the list was run, and try to find that person, or to try to engage with staff at that location to try to see if they could help find the person. Here at the health plan where I'm working now, you know, something unique that they have that everyone might not have is access to information on current inpatient hospital admissions. And that's something that we check every morning to see if any of the people we're trying to find here are in the hospital, because that's a great time to try to find someone. But Catherine, do you have other stuff you can say about that?
I think, you know, persistence and creativity. You know, really, you know, we would joke around that we were like Nancy Drew, you know, a lot of the time, just trying to figure out where people are. And on like sort of a similar note, it's like when the outreach component is really looking at some of them, you know, like really like how do you, it goes right in hand with engagement. It's like you might be able to find them, but then how do you actually engage them in wanting to change something? Because many of them, like, they don't think that anything's broken, you know. So even asking somebody, you know, is there, you know, so saying to somebody, you know, what can I help you with? A lot of them are going to say like nothing, for all sorts of reasons. Saying something, well, is there anything that could be better? Goes a long way. So, so I think, you know, outreach strategies are important, and engagement strategies is a close second as far as being able to, once you find them, how do you actually get them enrolled?
Great, thanks. We have just a couple more minutes. There's one more question that came up. You touched upon it a little bit before in terms of the predictive modeling, but can you talk a little bit about sort of the variables and what data were used in the predictive modeling?
Oh, sure. It's based entirely on Medicaid administrative data. So the main things that are drivers of someone being high cost and at risk for an admission in the next 12 months is their health services used in the 3 years before. So were they high cost? Largely by it's inpatient admissions, so do they have a lot of inpatient hospitalizations in the prior 3 years, somewhat by emergency department visits, and also, interestingly, and a little bit less so, but still driven by outpatient services use. So if someone is going to see a lot of different specialists and has a bunch of outpatient appointments with a lot of different people, then that is also a driver. But it's primarily driven by inpatient hospitalizations. And so I know it's difficult to get this much data, and so I think, you know, if you can go ideally at least like 2 years back and get people that have been, you know, have had a number of hospitalizations or a combination of hospitalizations and emergency department visits over the past 2 years, you know, there's a decent likelihood that that's going to continue on. If you only have 1 year, it's a little bit harder to say because a lot of people that are high use in 1 year will not be high use the next year. So you kind of do the best you can, but that's the way that it works.
Okay, great. Well, I think we're just coming up on 1:30 here, so thank you to both very much, to both of our speakers, and thanks to everyone for joining today's call. Just as a reminder, the slides will be up on the website. You can see on your screen here in about within the next week, and it sounds like might be able to post that assessment as well. So thanks again for everyone's participation.
Thanks.
Thank you.